So I'll be presenting a clinical case report of a case of marginal mandibulectomy and how we went ahead with the prosthetic rehabilitation using implants for this case. So this case was a case of carcinoma of the alveolus. Out of all the oral cavity malignancies, it is around 9 to 15% of all the cases, and usually it will require aggressive segmental or marginal jaw sections. So this was my patient. She is a female, 45-year-old female. She reported to the department after getting the diagnosis of this carcinoma of the alveolus and was required to undergo resection. So she came to our department after the consultation so that we can plan the implant placement along with the resections on the same surgery. So, according to the classifications, the first classification, the Cantor-Curtis classification, in my case falls under the class 1. That is, we are giving a mandibulectomy defect with alveolar resection done while the mandibular continuity was maintained. And according to the Boyle classification, it comes under type LC. That is a lateral defect and the central defect of the one side while the contralateral side is preserved. So the first stage surgery, the bony resections were done, the tumors were removed, and then it was followed by the formation of a proper bone block that will preserve the vertical height for the prosthesis later. Secondly, on the same surgery, we placed the endorsal dental implants, which will be used for the rehabilitation later. So after 6 months of healing, this was a 6-month follow-up. As you can see, there is a good flap healing seen in the left image. There was good bony remodeling and the flap also covered the proper residual ridge which was there. However, there was a bulky tissue present. So next procedure was the surgical debulking. Here we will be removing the thick mobile tissue flap so that we have a stable base for the prosthesis and keratinized tissue is present. If we skip this step, then we end up leading to formation of pockets which around the implants and which will prevent proper implant healing later on. So after this was done, it was allowed to heal. Then second stage surgery was done. That is, the implants were exposed. Now for this, we gave circular tissue punching over the healing screws which are there. After exposure, we added the transmucosal abutments directly, and then recontouring of the tissue was done around that peri-implant mucosa, so that we get a proper collar surface around the implant. Following this, we went ahead with vestibuloplasty because there was no vestibular depth present after the resection. A vestibuloplasty was indicated. So in this case, after vestibuloplasty was done, we need to give a stent to preserve that depth which is created. So in such cases where there is no vestibular depth, we need something to hold the stent into place. So we utilized 3 of the implants using the locator attachments to augment the acrylic stent and keep it in place. Following this, healing was allowed. After that, there was a little bit of tissue hyperplasia as seen here. So mandibular flap segments were reconstructed using vascularized free grafts. Because of this, there will be some amount of hyperplasia under immediate loads. So after the healing stent is removed, this will have some amount of healing required. So over the next 2 to 3 months, the soft tissue was allowed and slowly allowed to heal. Once that was done, the bulk tissue which was earlier present, that turns into a tight, firm and healthy attachment zone. For that, we will get a proper tissue bed onto which the prosthesis will sit. After this, the open tray impression is made. using the elastomeric impression material, and an intraoral resin jig trial was done. After this was done, we went ahead with the trial of the bar. Onto this, we planned for, because of the vertical cantilever which was present, we planned for a hybrid type of denture. And following that, we will be doing the jaw. And as you can see in the image, we did the wax trial of the same patient. Then this was the final prosthesis. It was an FP3 prosthetic, screw retained bridge. Here, because we are using acrylic, we are able to reduce the vertical cantilever. Also, we are able to PG. As you can see, there is a highly stable crestal bone level seen around all the endogenous implants. And using the FP3 prosthesis, we are able to give a fixed prosthesis to the patient along with a stable and a longer life for the prosthesis. This was the pre-op and the post-op of the patient. The lip posture and the facial aesthetics were maintained. Plus, because of the marginal mandibulectomy, there was reduction in the vertical support, which was also gained by this prosthesis. So, conclusion, the success of restoring a marginal mandibulectomy defect will mainly be close contact with the oncological surgeon, the prosthodontist, and the technician. And a lot of digital planning goes into it, which will require which will give us a highly stable, predictable tissue and bone bed, giving us stable implant prosthesis later on. Thank you.
Good evening, everyone. Today, I'm here to present my paper titled Clinical Outcomes of Transcrystal Sinus Elevation in Severely Atrophic Posterior Maxilla with Residual Bone Height of 5 or less than 5 mm, a systematic review and meta-analysis. So I actually want to start not with the slide, but actually with a question. The same question that started this whole project for me. A few months ago, our college actually began a value-added course on implantology. And as a part of that, we were searching for suitable patient to treat. While screening cases, I noticed something quite interesting. A large number of our patients in the posterior maxilla had severely resorbed ridges and the residual bone height of just 4, sometimes even 3 millimeters too. So the textbook teaching told me that if residual bone height of less than 5 mm, just go for a lateral window. So that is the traditional answer. But when I actually went and digging into the literature to justify the plan, I couldn't even find one clear and consolidated evidence-based answer on whether the transcrystal, the minimal invasive route, could just work even in the severely atrophic range. The question is what became the systematic review and the meta-analysis. Let me walk you through what we found. So the maxillary sinus is the airspace that limits how much bone we have to work within the posterior maxilla. When teeth are lost here, nematization and the resorption often leave us with very little residual bone height. And traditionally, we have 2 doors for the sinus. On the left side, we could see the direct technique, the lateral window approach, well-established one, but more invasive. On the right side, we could see, the transcrystal approach, osteotome or the instrument base entering through the crystal itself, elevating the sinus flow from within the implant socket. And this is really the why of a project. The evidence around the transcrystal elevation in this severely atrophic subgroup of bone height 5 or less than 5 is limited and scattered. And the studies differ in the surgical technique in whether they use graft or not in the implant protocols. So this heterogeneity make it hard for a clinician, to make a.
Yeah, you can continue. Please raise your voice and explain, okay?
Sorry, I will tell you. Sinus lifting surgery is basically done in case of dental implantology where there is insufficient bone volume present in the posterior maxillary zones. So the goal is to create enough bone in the sinus cavity such that it can support the implants, such that you can give a successful prosthetic rehabilitation. So nowadays we have this various techniques available for this sinus lifting purposes. That is relatively done with the help of indirect sinus lifting procedures, which is relatively minimally invasive as compared to the lateral window technique. Also, there are other techniques such as also densification with the help of denser burrs or hydraulic sinus lifting techniques are also available, which are shown to have improved implant stability, which can reduce the surgical morbidity. So the indication of the sinus lifting procedure is basically when there is a bone loss due to tooth extraction and there is bone deficiency following a trauma or a disease. And also if there is any congenital defects or sinus septum is already enlarged in situations. So the objective of this case report is to clinically evaluate and see the outcomes of how the osteodensification with the help of this denser burst and also the hydraulic sinus lifting techniques will have an effect on the implant placement. Again, within conjugation with the putty graft material that we use. So in this case, we have used osteodensification with denser burst. So in this, a 38-year-old female patient who has come from Iowa who wanted to replace her missing upper left back tooth since 5 months back. She wanted to retain that tooth, but it was the endodontic prognosis of the tooth was very poor, and she had to go for an extraction 5 months back. Systemic evaluation showed that they had no relevant history, but her father was a bit diabetic. And also there is no other relevant habit history that was noted. So on the intraoral examination, she had a missing 2.7 and also there was caries in 2.8, which was eventually extracted during the course of the treatment. And also she had a good oral hygiene. So these were the preoperative photographs of the individual. And in this, we have basically selected an implant size of 4.5 to 10 mm. We have utilized denser burrs, which is shown in the picture 3. This is the first stage surgery that we have done. We have utilized acrylic stents such that it can create an implant angulation or positioning can be done correctly. And later an incision was made and entire procedure was sequential drilling was done. And later osteodensification with the help of this denser burr was done. And later graft placement was done, followed by that implant was placed. So this is the image shows the biopia post implant placement as well as the stability was checked with the help of an ostel. So these were the post-operative intraoral photograph as well as radiograph of the patient. And in case of case 2, it was a completely digital protocol that we have followed. It is in case of a 33-year-old female patient, she wanted to replace her upper right back tooth, which was extracted in caries 3 years ago. There was no relevant medical or family history noted. And in case of the intraoral examination, she had a missing 1.5. Overall hygiene of the patient was relatively fair and some amount of stains were present. These were the preoperative photographs of the individual. The armamentarium that we have used, it is a digitally guided technique, and also we have utilized DO sinus kit for the purpose. So this is the first stage surgery that we have done. Surgical guide was placed, and later sequential drilling was done with the help of the drilling kit. And then an instrument was used to check for the the positioning of the sinus membrane. And later, we have utilized the help of another instrument through which sterile saline was asked to flow through the instrument, and such that they create some amount of hydraulic pressure in those regions, such that it will lift the sinus membrane eventually. And later, graft was placed, and implant placement was done, and then stability was then again checked in this situation as well. So this is the second stage surgery we have done. The healing abutment was placed and also prosthetic faces was also already done. The patient was given a metal ceramic screw retail prosthesis in this situation. And in the results, in case of the case 1 that we have done with denser burrs, we were able to lift the sinus membrane for about 3 mm, and also the stability that we have gotten was 66. While in case of case 2, which was a digitally guided technique, we were able to lift the sinus membrane for about 4 mm, and also the implant length that was placed was 10 mm. The stability that we have gotten was 76. So from this, we were able to conclude that both these techniques, that is digitally guided technique and the minimally invasive technique that we have utilized with the help of these denser burrs, along with the conjunction with a grafting membrane, can demonstrate much better clinical outcomes. Currently, we are in an era where we want patient-centric outcomes. So these procedure has also reduced the surgical time as well as post-operative discomfort of the individual. Especially if you're going in for a digital technique with implant ankylation or where there is a residual alveolar which is very much reduced. In those particular situations, we can go in for an indirect sinus lifting procedures. All the while, it aims to create an stable implant with fewer post-operative complications. So this this is as well as a minimally invasive technique, or which is alternative to a conventional technique that we follow. While it has its own restrictions, that is in between 5 to 10 implant, residual bone height is present, we can only go in for this minimally invasive technique. So these are my references. Thank you.
Now,
Good evening, all. Today I am presenting a case report on implant supported rehabilitation in a stage 4 grade C periodontitis patient. Advanced periodontitis often leads to severe alveolar bone loss, pathological tooth migration, and compromised oral function. Implant rehabilitation in periodontitis patients requires careful periodontal stabilization and bone augmentation, and also periodontal stabilization through supportive periodontal therapy. This case demonstrates successful implant supported rehabilitation following a socket preservation using sticky bone. Coming to the patient history and clinical findings, the patient was presented with complaint of missing and mobile lower anterior teeth, and we came into the diagnosis of generalized periodontitis, which is stage 4, grade C, unstable. Coming to the clinical findings, there is grade 3 mobility of 3 1, 3, 2, and also pathological migration of the mandibular anterior teeth. The overall prognosis of those teeth were considered to be poor. This was the clinical photo of when patient first came to our department. In these findings, we can see that there is a missing of 3-3, a grade 3 mobile 3-1 and 3-2, and also a ill-fitted fixed prosthesis, which also causing a secondary caries in the 4-4. So we plan for a treatment planning. The treatment options discussed were removable partial denture, fixed partial denture, but patient declined those prosthetic options, and we plan for an implant supported rehabilitation. The OPG evaluation was done and found that there is insufficient alveolar bone support, and also we know that the patient is suffering from periodontitis stage 3 grade C, stage 4 grade C. We gone for a traumatic extraction of the tooth, which was grade 3 and also having secondary caries. The traumatic extraction was done in order to maintain the buccal plate to avoid further bone resorption. After extraction of the hopeless teeth, we performed a socket preservation using sticky bone graft, which was formed using particulate bone graft mixed with the injectable PRF. The objective was of using socket preservation was to preserve ridge dimension and also to improve implant site quality. The healing phase was maintained for 6 months. This was the photo of using a sticky bone for socket preservation of the after a traumatic extraction. Primary sutures were provided to provide the primary closure and better healing of the site. These was the photos of healing after 6 months. We can notice the reconstruction of the alveolar ridge due to the socket preservation. A ridge resorption is not present, and a reconstructed alveolar ridge can be seen in that area. After 1 year of socket preservation, 3 implants were placed at the site after surgery. After 6 months of 1 year after the therapy, three implants were placed in the mandibular anterior region. A temporary removable prosthesis was provided during the osseointegration phase. The healing was uneventful, and meticulous oral hygiene maintenance and supportive periodontal therapy were reinforced between 3 months in order to maintain the patient's oral hygiene and periodontal stabilization. After removal of the gingival former, this was the photo. In the IOPA taken, we can see that after 1 year of the implant placement, the implant shows a better osseointegration with the bone, and there is no bone loss around the implant. Coming to the final prosthetic rehabilitation, after 1 year of the implant placement, implant-supported fixed prosthesis was fabricated. Thus, the functional and aesthetic rehabilitation of the mandibular anterior region was achieved. And also, patient was enrolled in a periodic supportive periodontal therapy because he was suffering from periodontitis, generalized periodontitis, stage 4 grade C. Coming to the discussion, the patients with stage 4 periodontitis present significant restorative and implant challenges. But successful implant therapy can be dependent on better infection control, periodontal stabilization, and maintenance. This periodontitis doesn't brings us a contraindication for implant therapy. But we just need for a better infection control, periodontal stabilization, and better maintenance during the implant placement, and also going further after the implant placement. The socket preservation using sticky bond may improve the ridge volume and also implant site quality, which doesn't require a further ridge augmentation before the implant placement. Strict supportive periodontal therapy is critical for long-term implant success in these type of patients like with periodontitis. This was the before and after of the patient photos. Before was the grade 3 mobile 3.1 and 3.2, and also a ill-fitted fixed prosthesis, and also secondary caries in relation to 4.4. But later we have provided a better functional and aesthetic rehabilitation in the lower anterior teeth region using placement of implant after the socket preservation and better after healing. Coming to the conclusion, the implant-supported fixed rehabilitation can be successfully performed in treated periodontitis patients. Then comprehensive periodontal therapy and maintenance are essential prerequisites in such cases. Socket preservation with sticky bond provided adequate bone support for implant placement in such patients. And thank you. These are my references.
Thank you, Doctor. We'll now open the floor.
Time starts now.
Good evening, everyone. Today I'm going to present a clinical report titled Fixed Implant Supported Hybrid Prosthesis for Rehabilitation of a Resorbed Mandibular Ridge Opposing a Conventional Maxillary Flexure, a clinical case report. So, introduction: a severe mandibular ridge resorption compromises the retention and stability of conventional complete dentures. A complete denture have been the most traditional means of rehabilitation of edentulous ridges. So this case report describes the rehabilitation of a severe resorbed mandibular ridge using a fixed implant supported hybrid prosthesis opposing a conventional maxillary complete denture. And this case report focus on the rehabilitation of mandibular resorbed ridges using all-on-4. So case report: a 64-year-old female patient came to the department with a chief complaint of missing teeth in the upper and lower teeth region of the jaw for past 1 month, because of which the patient is functionally affected. Past medical history was insignificant, and past dental history revealed the extraction of multiple teeth due to periodontal involvement. Clinical findings: a complete edentulous maxillary and mandibular arches, severe resorbed mandibular residual ridge, healthy oral mucosa with no signs of inflammation. Clinical and radiographic examination are performed. So treatment plan: so according to 4 endogenous implant planned in the interforaminal region, surgical implant placement, a healing phase for osseointegration, and it's planned for screw retained fixed implant supported hybrid prosthesis opposing a conventional maxillary complete denture. So this extraoral examination reveals that sunken cheeks with a sagging lips. And coming to intraoral examinations, reveal completely edentulous maxillary and mandibular arches with overlaying healthy mucosa. So, coming to radiographic study, the CBCT revealed adequate length and width of the bone in the canine region corresponding to the radio-opaque marking, satisfactory for conventional implant placement. So, treatment option is implant retained fixed prosthesis were advised to the patients. So, these are the CBCT evaluated in the both arches before planning of the implant. So CBCT evaluated and virtual implant placed in the anterior region, 2 implants 3.5 cross 13 mm in lateral incisor region, and posterior region 3.75 cross 11.5 mm in the premolar region. So coming to the surgical phase, the surgical sites was prepared and the LA was given bilaterally, envelope-like insertion was placed on the alveolar ridge, extending from the right premolar to the left premolar region, and mucoperiosteum were reflected. So after the flap elevation, the pilot drilling was first to establish the implant portion and angulation, and followed by sequential drills. Subsequent drills of increasing diameter was used to gradually prepare the osteotomy site, and the placement of multi-unit abutment, and to verify the implant, and paralleling check for the implant angulation. So, and suturing was done. So immediately post-operative OPG after implant placement was evaluated, which is satisfactory, and the patient was reviewed after 10 days for the suture removal. So a healing period of 3 months for allowed for osseointegration with monthly follow-up, monthly follow-up visits. So the radiograph was evaluated for the first 3 months, first month, second month, and the third post-operative OPG was evaluated. So coming to the prosthetic phase, after a regular follow-up for the 3 months, which at the second stage surgery was performed. Gingival tissue was allowed to mature to facilitate the development of proper gingival emergence profile for the anticipated restorations. So after multi-unit abutment of adequate gingival height and angulation were placed, impression copings were placed, and intraoral splinting of coping was performed using floss and auto-polymerizing pattern designs. So these are intraoral splinting of impression copings were used. And the pickup impression of splinted coping was made using the polyvinyl siloxane material, and implant analogs were placed. The gingival mask was injected, the working model was obtained, and jig was fabricated on definitive cast using auto-polymerizing pattern resin and verified intraorally for passive fit. So we the fabricated of the impression tray to check the delicate fit and the impression made with the polyvinyl siloxane material. So after this, jig trial was fabricated and continued with the jaw relation. So after jig verifications, the OPG was evaluated to see the accuracy of the implant. So the reflective cast using some metal bar was fabricated through intraorally, followed by an OPG to assess the proper fit metal bar, jaw relation, and drying were performed in the conventional manner, following which processing of hybrid processes was done. A prosthesis was inserted and final torque of 30 N was given to retention screws. The access bolts were secured using composite post-operative instruction regarding the oral prosthesis hygiene was given. So these are the post-operative of the insertion. So coming to the discussion part, the rehabilitation of resorbed ridges, especially that of the mandibular ridge, is challenging due to reduced bone volume caused by the long-term edentalism. So implant minimize bone loss, denture instability, sore spots, and discomfort, which improves the masticatory efficiency, leading to higher level of patient satisfaction. Implant-supported fixed hybrid processes provide improved retention, stability, masticatory efficiency, patient satisfaction. So implant retained processes have a significant increase in biting force, chewing efficiency, leading to enhanced quality of the life of the patient. So the placement of long tilted implant in the posterior region provide biomechanical advantages, including increasing AP spread, reduced cantilever, improved load distribution, cross-arch stabilization, and preservation of margin bone height. All-on-4 implant was chosen for the case as there was reduced bone in the posterior region. Thereby, tilted implant was chosen for the posterior side to avoid the placement of short implant and avoid the anatomical structure. So coming to the conclusion, the present case report described the rehabilitation of mandibular ridges using implant-supported hybrid processes to fulfill the desired expectation of patients, taking into consideration and treatment time and financial constraints, and provide other psychological benefits such as boosting confidence, enhanced social interaction, emotional well-being, and an overall improved quality of life. Thank you.
Thank you, Doctor. We will now open the floor to our esteemed judges.